Welcome everyone. Myself Dr. Sagar Ketia. I am assistant professor in Mehta Hospital. Today we will discuss about a very important topic, familial hypercholesterolemia. Incidence of premature CAD is rising. Familial hypercholesterolemia is one of important cause for premature CAD. So we will discuss today our topic in this outline. First we will discuss about introduction, then LDL structure and metabolism, then genetic and inheritance, then prevalence and natural history of familial hypercholesterolemia, clinical presentation, what are the how we should screen for patients for familial hypercholesterolemia, then diagnosis and management. So association between cholesterol and atherosclerosis was first proposed by Adolf Windius in 1910. Then cholesterol and coronary artery disease link was further established by Dr. John Goffman in early 1950s. In later century of 20, research in lipid biology improved understanding of atherosclerosis and led to development of lipid lowering medications. Familial hypercholesterolemia was first described by Dr. Karl Muller in late 1930 in a landmark paper which described as hypercholesterolemia and tendinous xanthoma were linked to cardiovascular disease through single gene inheritance. Familial hypercholesterolemia is a disorder of lipoprotein metabolism characterized by autosomal dominant inheritance, markedly elevated plasma LDL-C level and increased risk of premature CVD. So first we will review LDL structure. So LDL has one envelope and one inner cholesterol, ester and triglyceride content. Cover is formed by free cholesterol and phospholipids. Phospholipids include phosphatidylcholine, lysophosphatidylcholine, and sphingomyelin. And in envelope there is also apolipoproteins like apolipoprotein B148. There are two pathways of lipid metabolism. One is exogenous and endogenous pathway. In exogenous pathway, we take lipids in our dietary intake, which is first by salivary lipase and gastric lipase metabolized in stomach, and then absorption of triglyceride happen in free fatty acid. So first fatty acid will be absorbed in intestinal brush border cell, then it will be incorporated in chylomicrons. Then through chylomicrons, triglyceride will be absorbed in peripheral tissues like muscle, adipose tissue and capillary endothelial cells. After metabolism of triglyceride from chylomicron, chylomicron remnant will be uptaken by liver. In endogenous pathway, VLDL will be secreted from liver, which then cholesterol from VLDL will be used by peripheral tissues like muscle, adipose tissue and capillaries, and then it will be converted in IDL and LDL. So these are table which describes some properties of different lipoprotein. Chylomicrons are primarily formed of triglycerides, which is triglyceride absorbed from intestine, while VLDL are secreted from liver. VLDL has 90 to 93% lipid content, while IDL and LDL has slightly lower LDL content but increased protein content. These are important apolipoproteins which are present over surface of lipoprotein. Apolipoprotein A1 and 2 has important role in structural part of HDL, while it also help as cofactor in LSAT enzyme and ABC1 porter. While APO-A4 is a structural protein of chylomicron and HDL. ApoB48 is a structural protein for chylomicron, while ApoB100 is a structural protein for VLDL, IDL and LDL, and also act as ligand for LDLR receptor. While ApoC1 has role in inhibition of LPL, while ApoC2 has a role as a stimulator of LPL, while ApoC3 has also important role in regulation of remnant clearance and inhibition of LPL. ApoE act as a ligand for LDL. Originally, classification of lipoprotein disorders was done by Fredrickson, Lee and Lacey in 1967 based on lipoprotein pattern on ultrafiltration. They have divided disorders in 5 categories: type 1, type 2, 3, 4 and 5. Type 1 is hyperchylomicronemia, where there is increased level of chylomicrons, while 2 is 2A and 2B, two classes. 2A is familial hypercholesterolemia, while 2B is familial combined hypercholesterolemia. Both have increased level of LDL. Type 3 is this beta lipoproteinemia, which has increased level of IDL, while type 4 are familial hypertriglyceridemia with increased level of VLDL. Type 5 is familial lipoprotein lipase deficiency with increased level of VLDL and chylomicrons. This classification is not in today's world not widely used. In today's world, primary hyperlipoproteinemia is divided based on single gene mutation. They are further divided in main three categories: hypertriglyceridemia, combined hyperlipidemia, and hypercholesterolemia. Hypertriglyceridemia has different classes like lipoprotein lipase deficiency, familial ApoC2 deficiency, ApoA5 deficiency, and GPIH BP1 deficiency. ApoC2 help as LPL lipase, so its deficiency will lead to increased triglyceride. While GPIBHP1 is anchor protein which help in LPL binding to capillary cells, so its deficiency also lead to increased triglyceride level. In combined hyperlipidemias, there are two main classes: familial hepatic lipase deficiency and familial dysbeta-lipoproteinemia. Familial hepatic lipase deficiency is a hepatic lipase enzyme deficiency, while familial dysbeta-lipoproteinemia is ApoE apolipoprotein deficiency. These hypertriglyceridemia and combined hyperlipidemias are all autosomal recessive, and they are relatively rare disorders. While hypercholesteremia is a major part of disorders. They are furtherly divided in familial hypercholesteremia, familial deficiency of ApoB100, autosomal dominant hypercholesteremia type 3, autosomal recessive hypercholesteremia, and citrullosterolemia. Most common type is familial hypercholesteremia, which has one prevalence of 1 in 2050 to 500 population. While familial defective ApoB100 is also more common, which is prevalence of 1 per 1500. Other disorders are rare. Hypercholesterolemias are autosomal dominant mode of transmission. So FH is generally caused by mutation in genes related to LDL receptors pathway. So we have already seen these genes: LDL receptor gene, ApoB, PCSK9, and LDR-RAP genes. Most common type is LDL receptor deficiency, which is in 90% cases causes of familial hypercholesteremia, while ApoB100 deficiency is caused in 5 to 10%, and PCSK9 receptor gain of function is cause of hypercholesteremia in 1% population. LDL receptor mutation are also divided in 5 classes. In first classes, there is a deficiency in receptor synthesis. In class 2, there is a problem in transport. In type 3, there is a problem at level of LDL receptor binding. While in type 4, there is a problem in receptor clustering in PET. While type 5, there is a defective. In type 5, there is failure to discharge LDL in endosome. Now we will see prevalence of familial hypercholesteremia. So heterozygous familial hypercholesteremia has higher prevalence with 1 in 200 to 1 in 500, while homozygous familial hypercholesteremia is relatively rare with prevalence of 1 per 1,60,000 to 3 lakh according to different studies. Familial hypercholesteremia accounts for 5 to 10% of coronary heart disease in patients less than 55 years of age. Natural history: presence of mutation in gene known to cause familial hypercholesteremia increase cardiovascular risk by greater than 10 to 20 fold, and high risk of development of CAD by 3rd to 4th decade in men and 1 decade later in women. In heterozygous familial hypercholesteremia, in male 50% develop CSD before age of 50, while almost all male develop coronary artery disease by age of 70. While in females, 12% develop coronary artery disease by age of 50, and 74% female develop coronary artery disease by 70 years. Homozygous familial hypercholesteremia, most individuals develop severe coronary artery disease before the age of 20. So it is very malignant form of coronary familial hypercholesteremia. Clinical presentation: Familial heterozygous familial hypercholesterolemia are most commonly identified after experiencing CV event at early age, while homozygous familial hypercholesterolemia are typically represented with pathognomic of physical findings in childhood like xanthelasma, tendon xanthoma, and corneal arcus. So, extensor tendon xanthomas are more specific for familial hypercholesterolemias, while xanthelasma and arcus cornealis are not specific clinical sign of familial hypercholesterolemia. Diagnosis. FH is clinically diagnosed on the basis of combination of physical findings, personal or family history of hypercholesteremia, early onset of ASCVD, and markedly elevated LDL-C level. There is no single internationally accepted criteria for diagnosis of familial hypercholesteremia. Different criteria are used like Simon-Broom registry criteria, Dutch Lipid Clinic network criteria, and MedPed criteria. So in Dutch Lipid clinical criteria, there is a 5 categories, and each category there is given points, and total of point are used for diagnosis of familial hypercholesteremia. If there is a presence of susceptible genetics are present, then it is given 8 score. If elevated LDL level is more than 8.5 millimole per liter, then it is directly given 8 score, and it will be diagnosed as familial hypercholesteremia. While its level is between 6.5 to 8.4, then given 5 point. Between 5 to 6.5, given 3 point. In clinical investigation, if there is a tendon xanthoma, then it is given 6 point, while arcus cornealis given 4 points. In family history, if a first degree relative has a history of coronary artery disease, then given 1 point. And if a first degree relative has a history of tendon xanthoma or already diagnosed case, then it is given 2 point. While if patient has a history of coronary artery disease, then given 2 point, and if a patient has a peripheral artery disease, then given 1 point. And according to these points, we can divide patient in definite FH, probable FH, possible FH, and unlikely FH. Simon-Broom diagnostic criteria also can diagnose familial hypercholesteremia. There are A, B, C, D, E, 5 criteria present. A criteria has positive when there is total cholesterol level is more than 290, or LDL level is more than 190 in adult, or cholesterol level in more than 260 in children, or LDL level is more than 155 in children. In criteria B, there is the presence of tendon xanthoma in patient or first or second degree relative. In criteria C, there is DNA evidence of mutation in LDL, ApoB, or PCSK9. In criteria D, there is family history of myocardial infarction in premature age. In type criteria E, there is total cholesterol level more than 290 in first or second degree relative. We can make definite diagnosis if there is a presence of C criteria, or we can or there is presence of A plus B criteria. In other combination, there we can diagnose probable familial hypercholesteremia. US MedPed criteria use only cholesterol level and age of patient for diagnosis of familial hypercholesteremia. These criteria increase sensitivity for diagnosis of familial hypercholesteremia, but specificity will be reduced. See, these are comparisons of different criteria for diagnosis of familial hypercholesteremia. Genetic testing. When we will give patient advice for genetic testing. So there are some benefits and limitations of genetic testing. Benefits include it leads to definitive diagnosis, and we can also diagnosis which specific gene is responsible for familial hypercholesteremia. It will be important for further counseling during pregnancy to guide patient about what is the chances of familial hypercholesteremia in offspring. It also will be helpful for cascade screening of first and second degree relative. While limitations of genetic diagnosis, it's higher cost. There is still pathogenicity of many DNA variants are not definitively established. In some patients with biallelic pathogenic variants express heterozygous familial hypercholesteremia, but not homozygous FH. And there are also limited professionals for pre and post test tentative counseling. Risk of cardiovascular events in patients with elevated LDL is greater with familial hypercholesteremia when compared to normal patient with high LDL level. Treatment may be not necessary in all patients with of familial hypercholesteremia, but a homozygous familial hypercholesteremia patient required treatment with early age. In patient with familial hypercholesteremia, we should have screened, taken detailed history, and perform various tests for diagnosis of atherosclerosis. So, which tests include stress echocardiography, CT coronary angiography, and carotid and peripheral arterial Doppler. ESC guideline suggests use of cardiovascular imaging for diagnosis and management of homozygous familial hypercholesteremia. It describes polyvascular subclinical atherosclerosis may be present in coronary, femoral, and carotid vascular territory in patients with homozygous familial hypercholesteremia. Patients with homozygous familial hypercholesteremia should receive echoevolution at early age for diagnosis of coronary artery disease and also aortic stenosis. CT angiography should be used when there is a clinical history or above age of 3 when we suspect coronary artery disease or aortic sclerosis. Carotid plaque are rather than increased carotid intima thickness is marker of early stage atherosclerosis. Coronary calcium score is less useful in patient with homozygous familial hypercholesteremia at young age. Invasive coronary angiography can be performed when patient is symptomatic. Screening for familial hypercholesteremia. Cascade FH registry demonstrated that diagnosis of FH occurred at a mean age of 50, by which time a patient is also already suffered from coronary or peripheral event. So, vigorous screening should be performed to diagnose familial hypercholesteremia at early age, so we can prevent development of coronary artery disease. Patient with elevated LDL-C and identify FH mutation is associated with significantly higher risk of cardiac risk. So, diagnosis at early age will be helpful. Screening in children. Earlier lipid screening at the age of 2 years is recommended if child has family history of early onset CAD in one or both parents, or if parent has elevated total cholesterol level of more than 240 mg per dl, or there is underlying cardiac risk factor such as diabetes and obesity. Universal cholesterol screening in childhood at the age of 9 to 12 may offer the best and most effective strategy for diagnosis of familial hypercholesteremia. Screening in adult. Primary CAD prevention and heterozygous familial hypercholesteremia should be suspected in patient with markedly elevated LDL level, family history of premature CAD, very high test level of LDL and total cholesterol, and physical findings of FH like tendon xanthoma, extensor aspect, xanthelasma, coronary arteries. For secondary CAD prevention, patient in whom atherosclerotic disease developed at a young age should be carefully evaluated for heterozygous familial hypercholesteremia. Management. The goals of treatment of familial hypercholesteremia is to reduce the risk of atherosclerotic heart disease. Therefore, as usual in patient with hypercholesteremia, management start with lifestyle modification, then it follow pharmacological therapy, and in extreme cases, lipoprotein apheresis and liver transplantation may be required. So, lifestyle modification include dietary changes, exercise, behavior modification therapy, and also management of other risk factors like hypertension, diabetes, and cessation of smoking, alcohol, and other addiction. So, dietary modification include restriction of total fat content below 30%, restriction of total saturated fat in diet less than 70% of total calories, restriction of carbohydrate level less than 50% of total food, and total cholesterol dietary intake less than 200 mg, increased dietary fiber intake more than 30 gram per day, and also sufficient protein intake like 15% of total calories. These are different trials which I have done for different types of anti-cholesterol lowering therapies. આ કટ કરી નાખજો, એક સ્લાઇડ છે ને ટેબલ. Now we will discuss different cholesterol lowering therapies. So first line of therapy and most commonly used is HMG-CoA reductase inhibitors like statin. In familial hypercholesteremia patient, it is recommended to initiate statin therapy as early as possible according to ESC and EAS guideline. In a long-term cohort study of patients with 2000 patients with familial hypercholesteremia without relevant CSD in Netherlands, patients treated with statin showed reduction of 76% in CSD compared to untreated patient. beginning in early in life reduce risk of CSD by threefold when compared with risk reduction achieved by lowering LDL-C level with statin started later in life. In patients with homozygous familial hypercholesterolemia, statin-treated patients showed 66% reduction in all-cause mortality and 51% reduction in major MACE events. Pravastatin is approved for use as early as from 8-year age, while other statins are approved from age of 10 years. Ezetimibe. It is inhibitor of Niemann-Pick C1-like protein cells of small intestine. It reduces LDL level by 25 to 30%. Improved trial found that ezetimibe therapy in combination with statin lead to improvement in cardiovascular outcome and incremental reduction in LDL-C level. In FH patient, enhanced trial not demonstrated significant difference in change in carotid artery intima thickness, but LDL level are decreased. ESC and ES guideline recommend initiation of lipid lowering therapy with ezetimibe added to and in patient when statin is not tolerated. While SEC and AHA recommend ezetimibe therapy in patients who cannot achieve LDL reduction more than 50% on maximum tolerated statin therapy or LDL level more than 100. Bile acid sequestrants are another medication which can be used for LDL reduction in patients with familial hypercholesterolemia. Colesevelam in combination with statin and ezetimibe resulted in 20% reduction in LDL after 12 weeks of therapy. Similarly, in patients with FH, colesevelam was shown to cause reduction in LDL in both combination or independent to statin therapy. Colesevelam is can also be used in pregnancy and lactating women. PCSK9 inhibitors are other class of therapy. PCSK9 enzyme reduce the level of LDL receptor recycling, so its inhibition leads to increased available LDL receptor, so it will reduce LDL level. Alirocumab and evolocumab are fully humanized monoclonal antibody which are inhibitors of PCSK9, while inclisiran is a small interfering mRNA which also reduce synthesis of PCSK9 intracellularly. Evolocumab can be given 140 mg every 2 weeks or 220 mg monthly. Alirocumab can be given 75 mg twice weekly or 300 mg once monthly, while inclisiran can be given twice yearly injection in 300 mg doses. These are costly therapies, but can be used in children more than 10 years with heterozygous familial hypercholesterolemia with when LDL is not controlled with statin and ezetimibe and other medicines. These are trials of PCSK9 inhibitors and other medicines. Bempedoic acid. It acts by inhibiting ATP citrate lyase, which inhibit de novo synthesis of cholesterol, which reduce LDL-C level by 18%, as demonstrated in Clear Harmony and Clear Wisdom trial. Liver specific action, lack of muscle injury, and increased incidence of hypercholesterolemia and gouts are reported with bempedoic acid usage. Mipumersen is other novel agent for reduction of LDL. It is ApoB antisense oligonucleotide which inhibit biosynthesis of ApoB, thus reducing hepatic VLDL production and secretion. In clinical trial, subcutaneous injection of mipumersen reduced LDL level by 25 to 28% in homozygous familial hypercholesterolemia and heterozygous familial hypercholesterolemia respectively. Major side effects of this injection include myalgia, fatigue, hepatic steatosis, local site reactions, and elevated plasma aminotransferases. Lomitapide is another useful medicine which acts by inhibition of microsomal triglyceride transfer protein, which is localized in endoplasmic reticulum. It reduces level of VLDL in intestine and liver. Lomitapide is also available orally and has been approved for treatment of homozygous familial hypercholesterolemia in US and Europe as add-on therapy. In multi-center study with this drug in patients with homozygous familial hypercholesterolemia, it reduced LDL level by 50%, 40% and 38% at 26, 56 and 78 weeks respectively. Side effect of lomitapide is also elevation of plasma aminotransferase and intrahepatic fat content. Mipumersen and lomitamide has been approved for reduction of LDL in patients with homozygous familial hypercholesterolemia by FDA. Evinacumab is another agent which act by inhibits as a monoclonal antibody for angiopoietin-like protein 3. It is licensed for usage in patients with homozygous familial hypercholesterolemia above 12 year age, and has been tested in ELLIPSE HOFH trial. It reduces LDL-C level by 50%. These are the effect of different medicines when there is a reduced LDL receptor function. So, in patient with reduced LDL receptor function, action of statin will be reduced, and PCSK9 inhibitor will be not effective in patient with no detectable LDL receptor. While lomitabide angiopoietin 3 receptor directed therapy are also useful in patient with no detectable receptor of LDL, and LDL apheresis is also useful. Lipoprotein apheresis, it removes LDL and VLDL and atherogenic lipoprotein particle from plasma. It is established safe and effective therapy, can be used as early as 4 year age and in children with more than 14 kilo weight. It is more effective than statin therapy in preventing atheroma. It can be used once weekly cycle and a cycle of 3 hours long, and can lead to lowering of LDL-C level as high as 65 to 70%. And survival benefit also demonstrated with use of lipoprotein apheresis. Liver transplant is also can be performed in patient with homozygous familial hypercholesterolemia who develop atherosclerotic heart disease at young age and not responding to all medicines, and can be considered as last resort in a patient with more than 500 mg LDL level or established coronary heart disease. Multiple case reports has been suggested where liver transplant has been useful in patient with homozygous hypercholesterolemia. Gene therapy is also under investigation for management of homozygous familial hypercholesterolemia. Pilot study was started in 1995 in USA for recombinant retrovirus use in 5 patients of homozygous familial hypercholesterolemia, but has inconsistent results. And other vectors are also has been tested like AAV8, and CRISPR based editing techniques are also under research. These are one of the guidelines for how to treat homozygous familial hypercholesterolemia. We can start with statin in combination with ezetimibe, and can add if LDL is not lowered by 8 weeks, can add PCSK9 inhibitors, and then we can go to plasma apheresis, or in extreme cases for novel therapies like lomitabide, angiopoietin 3 directed therapy, and last resort is liver transplant. Pregnancy in familial hypercholesterolemia. So before considering pregnancy, patients should be counseled for family planning, and cholesterol testing should be done also of partner, and screening of familial hypercholesterolemia should be screened for partner. Cardiovascular evaluation is recommended in patients with familial hypercholesterolemia before pregnancy for risk assessment of coronary artery disease. Serum LDL level can increase by 25 to 50% during second and third trimester of pregnancy. Statin and ezetimibe are not recommended in pregnancy and are advised to discontinue 1 to 2 months prior to conception. Lipid lowering therapy which are safe during pregnancy are bilateral sequestrant like cholesterol and lipoprotein apheresis. Homozygous familial hypercholesterolemia should be offered weekly or fortnightly LA during pregnancy and lactation. FDA recommend changes in statin contraindication for pregnant women recognizing favorable risk-benefit ratio in high-risk patients. If lipid apheresis is unavailable, then continuation of statin therapy or reintroduction of statin therapy during second to third trimester should be considered. Thank you.